Okay.
Can you hear me?
Yes, who is that?
I'm from Lima, Peru in South America. I'm Roxana Brasky.
Ah, well, thank you for joining us. We're just about to begin right now. I'm just getting to the full screen, so welcome. We do ask if there's any background noise for anyone to please mute yourself. We will be opening up the mics at the end so that we can have discussion, and until then, we really look forward to your chat in our chat box. So please feel free to also write and for everyone to introduce yourselves there. So I'm gonna get started and welcome you all to our webinar. And there are two of us right now, the co-chairs of the International Childbirth Initiative that will be presenting this morning. Dr. Lalonde, would you like to say a hello?
Yes, good morning, everyone. My name is André Lalonde. I'm a professor here, obstetrics gynecology at McGill and University of Ottawa. I've been working on this project with IMBCO since many years.
Thank you. And I'm Debra Pascali-Bonaro. I've been chair of the International Mother-Baby-Childbirth Initiative and co-chair of the EC. And I'm really looking forward to being here and hearing all your thoughts and comments. And for those that are watching this after the fact, we still look forward to hearing from you too. So let's tell you a little bit about the International Childbirth Initiative, 12 Steps to Safe and Respectful Mother-Baby-Family Maternity Care. So the EC has a human rights framework for women and infants building upon the White Ribbon Alliance Charter on Respectful Maternity Care, the universal rights of childbearing women, as well as the rights of newborns and infants as formulated in the position paper on infant rights, which affirms the specific rights of infants beyond those already mentioned in previous UN conventions and documents. So the EC has integrated current thinking regarding quality in healthcare, aligning with the shift in how quality of care is defined and how it can best be delivered in healthcare systems. We'd like to show at this time, we have 16 endorsing partners. We know that there are more in progress. We hope maybe some of your organizations will be in the future, but you can see we have FIGO, the IMBCO, we have the ICM, the IPA, White Ribbon Alliance, ICEA, DONA, Lamaze, Harvard School of Public Health, the ACNM, Mercy in Action, Bhumi Sehat, Midwives Alliance of North America, the Sanctum, Midwifery Today, and Every Mother Counts. So I know I've seen a few of you as partners are on the call, and we thank you for being here with us, and we look forward to your involvement. So why the EC? So a little bit of history. In 2008, our mother-friendly childbirth initiative in the United States became an international global initiative called the International Mother-Baby-Childbirth Initiative, 10 Steps to Optimal Care. And we were quickly translated into 26 languages and integrated into birth practices around the world. In 2014, the International Federation of Gynecologists and Obstetrics, FIGO, collaborated with the World Health Organization, the International Confederation of Midwives, the International Pediatric Association, and the White Ribbon Alliance to create the FIGO guidelines to mother-baby-friendly birthing facilities. It was soon realized that the two documents were similar, and so a merger would allow for a more effective use of resources for implementation, monitoring progress, and documenting results. So we are proud to launch the International Childbirth Initiative, which has combined and updated these two documents into one comprehensive set of principles and steps that maintain a focus on maternal and newborn rights, including the most recent evidence and integrating current thinking, defining quality healthcare that is effective, safe, and in keeping with the preferences and needs of the people and communities being served. So we are really looking forward to hearing your thoughts as we also work to broader network implementation. So respecting the mother baby, and if you notice, we write mother baby as one word. So capital M, capital B, no space between them on paper, so that there's no space between them in life. And this is recognizing their interrelated, complex neuroendocrine bubble and how one intervention will affect the other. We also look at the hormones, oxytocin, prolactin, endorphin, and cortisol, as Dr. Sarah Buckley and others have well documented in the hormonal process and the hormonal physiology, that one intervention, feelings of stress or fear, pharmacological or physical intervention, will affect both. Any provision for the mother or baby significantly affects the other. Then we look at that the mother-baby family-centered maternity care. So mother-baby-family looks at this as an integral part from preconception through pregnancy, birth, and infancy, and including the health all the way up to the age of 2 is a window of opportunity for parents and caregivers to lay the foundation of health and well-being to last a lifetime and to positively affect future generations. So mother-baby family-centered care shifts the care from traditional medical model to a medical and value-based model, where the health needs and expectations, as well as the desired health outcomes, are the driving force behind decision-making and quality maternity care. So the ICI is aligned with recent guidelines. Many of you are knowledgeable about these. The Blueprint for Advancing High-Value Maternity Care Through Physiologic Childbearing draws upon the evidence showing the short and long-term benefits to the mother and baby achieved by supporting the hormonally driven physiologic perinatal process. The WHO document, Standard for Improving Quality of Maternal and Newborn Care in Health Facilities, recognizes that such importance is an important focus in ending preventable maternal and newborn mortality and morbidity. And then the WHO recommends an antenatal care for a positive pregnancy experience and interpartum care for a positive childbirth experience, both of which underline the importance of meeting the needs of mothers, babies, and families. In addition, we included the framework for nurturing care for early childhood development, which sets out a roadmap for action, referring to the role of maternity care services during pre-pregnancy and through the postnatal period. We also looked at the recent Lancet series on midwifery and other midwifery guidelines. So we really did an incredibly thorough research on current guidelines, and we are in line with all of them. Our founding principles. This is really important to us, and I'm going to briefly summarize them, but our document actually has them all really spelled out, so I hope that all of you may have already looked at the document, which you can download off of our website, internationalchildbirth.com, and if you haven't, that you will take a look at it after. So our principles are advocating rights and access to care, so women and children's rights are human rights and must be ensured in all settings and circumstances. We're ensuring respectful maternity care, considerations, respect, and compassion for every person and newborn should be the foundation for all maternity care, even in the event of complications. And every person, mother-baby unit should be protected from disrespectful or violent practices of any kind, as well as any infringements on their right to privacy. We are protecting, as we already mentioned, the mother-baby-family triad and how integral this is to achieve the full potential of safe and respectful maternity care. We are promoting wellness, preventing illness and complications, and ensuring timely emergency referral and care. Pregnancy, labor, birth, and breastfeeding are most often normal and healthy physiologic processes that require supportive care and skilled attention. Many pregnancy-related and newborn complications can be prevented or attenuated by primary maternity care and public health measures designed to prevent illness and promote wellness. Accessible, appropriate, and effective maternal and newborn emergency care is essential for the reduction of maternal and neonatal morbidity and mortality. Our next principles go on to supporting women's autonomy and choices to facilitate a positive birth experience. So continuity of supportive care and sensitivity to the birthing person's cultural, religious, and individual beliefs and values reduce the risks of psychological trauma and enhance women's trust in their caregivers, their experiences of childbearing, and their willingness to accept care and to seek it in the future. Women should have a full range of choices throughout their maternity care experience, including risk-appropriate choices for their place of birth. And women with normal low-risk pregnancies can safely give birth outside of medical facilities in clinics, birth centers, and home when skills care and effective referral are available. We also talk about providing a healthy and positive birthing environment and the responsibility of caregivers and health systems in establishing a caring and supporting atmosphere, listening to the mother, encouraging her self-expression, and ensuring the equal communication interchange in language a woman understands in order to achieve individualized care is an essential aspect of culturally safe and respectful maternity care. We also go on that healthcare systems are equally responsible for providing safe environments that take in the needs of providers into account, and we'll go into this more later. We use an evidence-based approach to maternal health services based on the mother-baby-family model of care. And using an evidence-based approach to maternity health services based on midwifery and family-centered philosophies of care. So at this point, I'd love to turn this over to Dr. André Lalonde to tell us a little bit about the steps themselves.
Thank you, Debra. So good morning to everyone. Thank you all for your participation, and we look forward to the discussion after this presentation. So the first step is to provide respect, dignity, and informed choice. Under no circumstance is physical, verbal, or emotional abuse of women, newborn, and families ever allowed. And each step, we have some indicators, and we're giving you an example of the indicators. In the full document, it's much more detailed as to how we're going to assess the indicators so that a hospital or a clinic that wants to qualify to be recognized as an ICI hospital or a birthing unit, then they can be assessed to see if they can reach that level. So the indicators here are there complaint procedures? Is there a woman's questionnaire as to their experience of labor and delivery? And to have in the birthing area a visible rights declaration so that when women and their families come for services, they can see this. Number two, respect every woman's right to affordable care with cost transparency. So we are really promoting free obstetrical care. But we understand that in some countries, this is not possible immediately. So we want to make sure that there is no under-the-table payments. There are no preferences if a woman pays somebody in the staff. No woman or baby be refused care or detained for lack of payment. So the indicators here is that we should not ask for special fees. If there are to be charges, it should be known. It should be told to the woman during their antenatal care, and at the entrance of the birthing unit, it should be on the wall somewhere, this is free care, or this is what we charge in the hospital. So I think this is very important And we want to have no cases of detainment, because in some areas, a woman or her newborn can be detained to have some payments. Next slide. Number 3, routinely provide mother-baby family maternity care. So here we are promoting multidisciplinary collaboration and communication. So really it has to be a team approach, not individualized approach, between midwives, obstetricians, nurses, pediatricians, and all the other allied health professions such as doulas, such as anyone who is part of the team in providing care at any setting and at all levels of care. So here we want to see the hospital, what's their care model? And we want to test whether the staff and women know about this model. And we do this through questionnaires and observations. Number 4, offer continuous support during labor and birth by a companion of choice. And we have ample international evidence that if we support a woman during labor and that she receives support from a family member or from a staff person such as a doula, she will have a better labor and delivery, and it's going to be more normal, and it's going to require very little medication if we follow this policy. So again, the indicators here would be a policy that is visible, written, and graphic, and that we see that really during the antenatal care, women are told about this, that they can have their the father of the baby, the mother-in-law, her sister, etc. Whoever the woman wants and feels comfortable with should be allowed to be present at labor and delivery. Still, we have too many hospitals in the world where women are left alone in units that are understaffed, and therefore this produces anxiety. And as Debra has explained to you a while ago, a lot of the hormones that are affecting women will affect the newborn. And it's very well known that if a woman is stressed during labor and delivery, then she will have dysfunctional labor, and this will lead to unnecessary medical interventions. The 5th item and step is to provide pain relief measures, offering drug-free comfort and pain relief measures as safe first options. In other words, when a woman is in labor and she seems to be distressed and requires help or is asking for help, we should then use non-medical interventions such as different positions, such as using the ball, such as moving the woman in different positions that she wants to alleviate pain. Only after we've tried this, if there is still no adequate control of pain as perceived by the woman, then she should be offered medication. So here again, the indicators is we need to see in the birthing unit or in the hospital protocols or information about non-pharmacological choice for women, responses from women and from staff. So it's very important in the 12 steps that the staff is working as a group, and as a group they agree to these policies, and we can see them recorded in the hospital or the birthing unit. Next slide. Number 6, provide evidence-based practices proven to be beneficial for mother-baby family throughout the entire childbearing continuum. So here we have indicators that you can see a poster. You can see that the staff has been trained. We want privacy, so it could be walls or it could be curtains. We need to see this in observation that the practices of all the healthcare professionals are evidence-based, and we need to see that the unit is working together to update their knowledge on evidence-based practices, and therefore any practice that is not evidence-based is not used in that unit. Number 7, avoid harmful practices that have insufficient evidence of benefit outweighing risk for routine or frequent use in normal pregnancy, labor, birth, or postpartum or neonatal period. So, you know, things like routine episiotomies, routine enemas, routine IVs, having a fixed position for labor and delivery. All of these are in the text. If you go online and see our full text, you will have a list of the procedures that we think are not evidence-based and that they're harmful. However, some of these procedures may have to be used in a high-risk pregnancy, and we spell them out. It's very important that the staff understands these and review the rates of procedures. What's the rate of episiotomy in the unit? What's the rate of forceps? What's the rate of cesarean section? We want to see a reduction in the number of vaginal exams, the number of episiotomies, so we can assess this through observations and through questionnaires. It is very important that women feel that they can ask for their preferences during labor and delivery, and they can bring this to the birthing unit. Next. Number 8, enhance wellness and prevent illness by implementing educational and public health measures. So here it's very important, and that's why we have partners such as the Doula Association, the Donor Association, such as the Leche League, etc., where we can see that in the pre and postnatal education, some of these principles are implemented, and that there is staff training on the different procedures that are implemented from WHO, such as the prevention of infection, washing of hands, etc. So there's a big emphasis on prevention. We think that through this, we can achieve a safer birth for the mother and for the newborn. Number 9, provide emergency care and transport. So it's very important in the promotion of natural childbirth that we have backup. And backup means that the staff has been prepared to deal with emergency situation and transport. So if a unit is a level 1 or a level 2, they already have agreement with a level 3 hospital or a referral hospital, and that transport is organized and prepared so that in an event of an emergency, the woman can be stabilized and it can be a very quick transfer. So the indicators here is, are drugs and devices and equipment present in the birthing unit? For example, do the midwives have access to tamponade? Do they have access to oxytocin drugs? Do they have access to magnesium sulfate in preeclampsia treatment? So we need to see evidence that the staff has been trained so that every year they can review what they're doing. They can review the main complications in maternity care, such as postpartum hemorrhage, preeclampsia, infection, etc. So we need to see this as a basis of the organization of care in that hospital or in that birthing unit. And again, we can provide evidence from this through questionnaire from women who have delivered in that birthing unit. Number 10, have a supportive human resource policy in place for recruitment and retention of dedicated staff. Here, what we have seen in many countries is that the units are understaffed. There's not enough personnel there. People work for 6 months to a year and a half, and then they're transferred. And so therefore the steps that have been taken to make sure that continuous education is available is lost. And if we don't have a policy to encourage staff to remain in their post, then the morcellation of care is very evident, and this is a problem in providing safe maternity care. Next, number 11, provide a care continuum with collaboration between healthcare educators, providers, institutions, and organizations. And this is where we can see that at the prenatal level, we need to be involved with other professions so that the education of woman is centered around her own needs and the needs of her family. This is very important, and that there is a link between the prenatal care and what's going to happen at the birthing unit. I remember many years ago in my hospital where prenatal care had no connection with the delivery of a woman. So therefore, what was taught in prenatal care was not transferred then into labor and delivery. So you need to make sure that wherever women are birthing, whoever's providing antenatal care has to be involved with the birthing unit so they can come and visit with the pregnant woman, or at least meet with them so that they can make sure that everybody's on the same page and listening to women's needs. As you see, I always keep referring to women's needs because we believe strongly that we need to respond to a woman's need, and the best person to know what is needed in labor and delivery is the woman herself. So we have also indicators here about assessing this. Number 12 is a long number 12 because it is to achieve the 10 steps in the revised baby-friendly hospital initiative. So I ask all of you to check on WHO in 2018, and this year, WHO and UNICEF revised the baby-friendly hospital initiative, and that's really to achieve breastfeeding, and so therefore no separation of the mother and the baby, skin-to-skin contact immediately at birth, early breastfeeding, no promotion of or free samples of formula, staff training and informational material visible, and especially in breastfeeding, we need to have someone who has an expertise in the birthing unit so that if a woman has difficulty in initiating breastfeeding, help is immediately available. So this is extremely important, and we detail this quite extensively in the document. We list the 10 steps, and through this, we have the support of the International Pediatric Society, and we're getting UN support from the major agencies as we are providing this new initiative. To you now, Debra.
So the indicators?
Yeah.
So we have indicators. The safe and respectful mother-family maternity care is measurable. Smart indicators will be locally adapted to country and setting context. And so these indicators will include medical outcomes, perceived quality of care, presence and visibility of policies, as Dr. Lalonde talked about, transfer of health information and knowledge, and really look at knowledge increase, as we talked about, both for the birthing people, the women, the fathers, the families, as well as the staff. A use of grievance mechanisms and client community participation. So suggested tools, and these are just suggested because as we go forward, we'll talk about implementation, where this is a learning collaborative process, would be routine medical data, women's questionnaires, observer data, checklist, reflective practice, random record review, and community scoring. So one of the things that I'm really excited about is that we envision that implementation will work with local community groups to ensure relevance, engagement, and acceptance of the end users. So whether or not the 12 steps are implemented as a whole or in phases can be determined locally. The EC coordination group will continually gather information on the process of implementation as it's being done in real time. We'll collate this information, analyze it, and feed it back to assist on ongoing implementation and new implementation processes. And in doing so, this will be a learning cycle. It will be created and maintained so that it will benefit implementation of the EC in all settings. Implementation can also be small or large, so individual facilities may be motivated and have the resources to start on implementation themselves, while in other situations, health managers and planners may initiate a process of implementation for a specific district or region. And the EC acknowledges and welcomes both scenarios. So I really hope that we can look at how this is a partnership that's supported by both governments, UN agencies, and health funding. In addition, it is essential to implementation that it's locally led with community involvement. And this is something that we really had great discussions around and is different than some of the other initiatives in the past. So it's based on a minimal package of evaluation and measurement tools and supported by international and regional experts in verification. And we do envision that this will be leading to a recognition status for facilities and practices as a part of an ongoing quality assurance cycle. And that recognition will be determined by the groups doing it. So there's a lot of local input, and we will contribute to the EC as an international ongoing learning initiative through assessment, but not burdensome, to be conducted positively with the intention of supporting and improving services as not as blaming and shaming. So we really talked about too, having local celebration, for each step that's achieved. It's not an overall pass fail, but we can really work together to look at each achievement and then to sustain them going forward. So,
let me just mention, Debra, something about the SMART indicators. We talked about that and we didn't spell them out.
Okay.
So SMART indicators are indicators that are used to assess healthcare delivery. So what it stands for is S is specific, M measurable, A attainable, R reliable, and T timely. So this is the kind of indicators that we will use in helping hospitals evaluate themselves. The evaluation will not be done by an international body, but will be done locally. And as Debra mentioned, we would encourage everyone to work towards achieving these 12 steps. Thanks.
Thank you. And would you like to talk, André, about going forward?
Yes. Well, what we're doing is that we're in the process in the next 4 to 8 weeks of having the development of indicators, how to assess a birthing unit. So we'll have an extensive questionnaire, first available in French, English, and Spanish, but already we have found volunteers who are going to work with us to develop these in multiple languages. And if in your own country you have a different language and you have someone who can translate this, please notify us and we will work with you. We are also developing the data set that we will be asking birthing units to send to us. So there will be a process where someone will write to the ICI and say, our hospital wants to become an ICI hospital. Then what will follow is that we will have a questionnaire sent out that can be filled by the hospital and sent back to us so we can do a preliminary evaluation. We are in the process of working with partners because in countries, we want the 3 main partners and the supporting partners, that is the pediatricians, the midwives, and the obstetricians, to work together to help a hospital become an ICI hospital. We will be establishing different committees and working groups for implementation, for research, and for coordination. Right now, many of you know that IMBCO have approximately 10 to 15 hospitals worldwide who are recognized as a mother-baby-friendly hospital. And these will be the first groups that we hope to work with in the beginning of 2019 to requalify these hospitals. It's not going to be an accreditation process. It's more going to be like a celebration, and we will develop a kind of a document that you can put at the entrance of the unit that will say you are an ICI hospital because you've implemented the 12 steps. Next. So go ahead.
We want to thank you for being able to share this with you today. We are new. Our website is just up, and at this time, we only have the initiative in English, but as Dr. Lalonde just said, we do have many people, some of you I think are on this call or listening later, that have offered to help to translate. Right now, I have 14 languages that are in process. So if you do have a language that you'd like to see the initiative translated in and you can help, you can see our mail is mail@internationalchildbirth.com, or if you want to reach us directly, it's exec, E-X-E-C, at internationalchildbirth.com. And as soon as we have additional languages ready, we will be laying them up and adding them to the website. So please go back there often and see what other languages are up. We will also be embedding this webinar on the website. So if you want to share it with others, you'll be able to probably within a couple of days. And we are new to Twitter, and so if there are aspects of the EC that you'd like to share, we would welcome you using our hashtag ECBirthChange. And it's another way that you can communicate and tweet out with us and with our partners. So at this time, I'd love to open up for discussion. And each of you that are here with us, you should be able to see that you have a little microphone next to your name, and you can on your own open that up and say a comment or question, or feel free to type in the chat box as well, and then we can read them. If you posted a question before, I'll try to go back and look through now because I wasn't able to follow the chat as I was talking. But anyone with a comment or a question that can unmute, please do.
Hi, Debra. It's Maxine Harding here. I'm not sure if you can hear me.
You have to speak louder as it's difficult to hear you.
Oh, okay. I'm really sorry. I'm not sure how to adjust the levels on my computer. I'm currently working in Nepal, and I'm working with a great group of nurse midwives, and we're about to develop a midwifery-led unit and family birth centre. How can we sign up to be part of your project to help establish this credentialing in our facility?
Well, as I mentioned a while ago, I think that the person responsible for your birthing unit should send us an email or through the website or through the contact, and we'll keep this with us. There won't be a response immediately because, as I mentioned in my presentation, we are developing the tools that will help you assess yourself. Is your unit able to respond to the 12 steps? And then automatically that would be recognized. It's not going to be an accreditation as such. It's going to be a recognition that you are meeting the principles and the quality of care, including the 12 principles.
Okay, great. Thanks very much.
All right.
Thank you. And please make sure, everyone, that you are joining our mailing list as well, because we will be keeping you updated. Like, the application should be ready, we think, in just a few weeks, right? For sites, André?
Yes.
And that way we can let you know as well through that. But we really look forward to hearing from you, and it was real exciting to hear the work you're doing, so thank you.
I could add also that those who have interest in this initiative and are willing to devote some hours, we have to, as I mentioned a while ago, we need to expand. The people who are working on this, we've been 4 to 5 people, supported by about a dozen people from IMBCO and a dozen people from FIGO. But now we want to have more midwives, more pediatricians involved with this initiative. And definitely, this is a volunteer organization. There is no paid staff at the moment. So, as I didn't mention, we are looking for some funding, maybe to help in the producing of the documents, to the follow-up, to the development response to the requests that we anticipate from around the world.
Any other questions? I see Betsy, hello, you asked, are there any places where the steps are in place, a model facility where this is working? And I think André answered that we do have several IMBCI sites around the world that we hope will be some of the first one. I know some of them are in progress. I can't see all our participants, but I think we may have someone here from Mercy in Action, and Vicki Penwell's group has been implementing and already working to update to the 12 steps. Bumi Sehat has in Bali in Indonesia and the Philippines is updating to 12. We have a site, and André, you might want to talk about it in Brazil. You were recently there at Sophia Feldman that is looking to upgrade. We have a Quebec site and an Austrian site, as well as in India. And would you like to say anything about the Brazil site, André?
Sure. I had the opportunity to be in Belo Horizonte, and they are a sentinel hospital for mother-baby care. And my visit there in about 6 or 7 hours, I can tell you they fully qualify as to go to the next step and become an ICI demonstration hospital. So in larger units and even smaller units, we will use some of the hospitals as an example for hospitals in that area. So we're hoping that we will have someone translate all the documents into Portuguese so that there is a lot of interest in Brazil. Similarly, as I mentioned a while ago, we have at least 3 basic languages. I'm hoping to have within a week to 10 days the Spanish version, and in about a month the French version, so that we will pursue the translation of these documents. I think there was a question here that was asked, what about family physicians? Because in many countries it's a general practitioner who is in charge of the obstetrical unit. There's no obstetrician. It's a good point. We are in contact with the International Family Medicine Group, so we're hoping that they will join us. And when you saw the logos today, there was one logo missing because at 6 a.m. this morning, I received a note from ICN, International Confederation of Nurses, that they have joined as endorsing our initiative. So we're very happy to see that now that we have another profession joining this.
Fantastic. And I see that Vicki is here. Vicki, I don't know if you can unmute to say hello and talk a little bit about your work with Mercy in Action and implementing the EC in the Philippines.
Hi, I'm glad to be here with you guys this morning. We're so excited about this switch to ICI. This is Vicki Penwell, and we have about 15,000 deliveries that we've done free in the Philippines since 1991. We started doing the mother-friendly care in 1998 and publishing things in the Philippines about that. But we're so excited now that it's merging with the FIGO steps, and we're working on getting it translated into at least 3 different languages at this point from the Philippines, and we are really looking forward to in the next year, 2019, to really talking about this all over, pushing it forward. Lots of interest, and we're excited to be a part. So thank you for all your hard work.
Oh, thanks so much, Vicki, especially for getting up early to join us. Thank you for all you're doing. And I see we have Johanna from Bangladesh. It's wonderful to see so many of you joining us from around the world. Are there any other questions or comments, or maybe a partner here also with a site that would like to share?
Maybe I can ask a question to some of you. What are the, if I can call them, barriers in your area to implement mother-baby-family care? You notice that we have added family now. For a while, there were organizations that were baby-friendly, then organizations that were mother-friendly. Now there were organizations that are mother-baby-friendly. But we firmly believe that including the family in the birthing process is essential for the newborn and for care after.
Great question.
Hi, this is Betsy. Can you hear me?
Yes?
Hi. Hi, Deborah. Thank you so much for doing this. So I live in a rural area in Florida, and there are several issues. But, okay, one is we don't have a midwife that has privileges at either of the county hospitals. And we do not have VBACs available at all. So people are leaving the county. Women are choosing home birth naturally. There are some birth centers, but they're about an hour away. So my thing is beginning with, let's somehow get a midwife that can practice, in the hospital. So it's very archaic.
Well, one of the things you can get very fast is you get the support of ICM, but also from the I think it's called the American College of Nurse Midwives. So I think you should contact with them to see what kind of support they would give you, and remind the American College of Obstetrics and Gynecology that they have endorsed this initiative that FIGO is putting together with other partners. So I think if you go to look at the full document, you will see these different organizations. And if I was you, I would start with the American College of Nurse Midwives. They will be able to tell you why in Texas this is not moving. Texas and Florida, you said, I'm sorry. And I think by asking the support of the midwives and the OBGYNs at the national level, you may be able to move things at the local level. And certainly grassroots support, having the woman who you serve write petitions, sign documents that they want, and they need midwifery services. I can give you an example here in Canada. I've been involved in the last 2 or 3 years with the Cree Indian population in the north of Quebec. They had to be transferred 3 hours by plane for labor and delivery, and we've just introduced this year midwifery services. It was a bit of a battle, I can tell you, at some point. But the biggest support we got to do this came from the woman and their families. And, that's why I think that men and women, if they get together and they request this, then you have, success after a while.
Thank you.
And André, I see a question for you since you are in Canada. Deanne says, I live in Canada and I'm wondering how to engage partners in a way that they will build buy-in.
Well, I think it's nearly the same answer as I gave to the person from Florida. There is an OBGYN society in Canada. There is, what we're doing now is that through FIGO, ICM, and IPA, IPA is the International Pediatric Association. We are driving down this document. We're sending it to them and asking that each of their member countries, there's 138 countries, I think, in IPA, there's 145 in FIGO, that they send this to their staff and to the local country organizations so that they're aware of this. And I think by doing this, you have a possibility of achieving your goals. Here we have a question, I think, or a comment from Hacken Cooker. 42 official state hospitals already called mother-friendly state hospitals. Wow. So this is really great. So I think this would be something that if we get the address of these hospitals, whoever's in charge of these hospitals, we would certainly be very interested in sending to them. So that would be very good. Whoop.
And he continues, is the EC thinking of international ways of controlling these already opened hospitals?
Yeah.
What would you, André?
I'm sorry, I nearly got cut off here by Zoom. So what was the question?
My question, this is also from Hakan, and hello Hakan, it's wonderful to see you here with us. His question is the EC thinking of international ways of controlling these these opened hospitals? In other words, the 42 that already call themselves mother friendly.
Well, I think the easiest, as I said, if we have contact, if we have the group, and what I like, it says official state hospitals. So really, I think that would be great if we could have wherever that state is, or the states, if there's many states. And I presume you're talking about in Turkey. Is that where you're talking about, Hakan?
Yes.
Yes. So I think if we have the name of these hospitals, at least the state, then this would be a great initiative for us to write to them, to send them the documents. And, I would presume that they would have no difficulty to become an ICI hospital.
And Hakan has volunteered to translate into Turkish. So the sooner we have that translation, right, then
Right.
Working with you to be able to write to them will be fantastic. So thank you.
All right. So that would be great.
And I saw, Cynthia, you were trying to unmute your microphone. So, and we'll take one more question before we have to go, but you should be able to, and I see it now, you've read that the White Ribbon Alliance, World Health Organization, or EC, are calling for more research. Debra and Dr. Lalonde, would you share specific research topics you would like to see conducted?
Well, it's a very widespread question. I think, every aspect, as I said, every aspect of care needs to be evaluated in a very scientific way. For example, right now there is a big concentration on prematurity, on stillbirth. So there's research being done. What causes prematurity? What causes stillbirth? And this is continuing. But on the woman's side, I think it's important that we, each area, try to assess whether their practice is woman-friendly or mother-baby-family friendly. So I think that is also very important.
Yes. Well,
And Debra Barker has also given us some answers that their research is ongoing. I think most midwifery organizations in most countries are doing some research, and they're doing it in collaboration.
yes. Well, I want to thank everyone for being here with us today. This is just the beginning, right? Today, and actually recently at the FIGO meeting, was our birth, so to speak. So we're gestating now, and we are a collaborative initiative. So we really welcome your involvement to join us. We're looking for people to be on committees, for sites, for translation. There are so many ways to get involved and to share. And we are also envisioning a continued webinar series. So we are looking in the coming months to start literally step by step, especially with our sites and organizations that are already implementing and doing well on the sites to collaborate. So I hope that you'll join our mailing list if you haven't already, right on our website, internationalchildbirth.com, so you get notifications. And if you're interested in helping present a webinar on one of the steps, please write to us. Again, ecexec@internationalchildbirth.com will go directly to André and myself and our other two, Claudia Hansen and Kathy Herster, for our executive committee. So thank you, and it's great to see you from all around the world here joining us today. I'll leave the chat box open for another minute or two for those of you that would like to share where you are and last comment. And again, thank you. We hope to see you soon on future webinars and on Twitter at EC Birth Change.